right, I think it's slowing enough. So I'm going to get started. So hi, everyone. Welcome. You have made it to the right place if you are here for the Northwestern Implementation Science Reading course. We're delighted to have you. We had record enrollment this year. This course started, I believe, 6 or 7 years ago with 17 people in a small conference room, and now we are almost 100 strong virtually. So we're absolutely thrilled to have you. This course is led by faculty at the Center for Dissemination and Implementation Science. And today's session will be led by myself and Dr. Corey Bradley, who is an expert in using implementation science as a tool for social justice making. And I'm thrilled to be talking with him today about shifting your focus and an introduction to dissemination and implementation science. All right, so here's a high-level overview of how we hope to spend our time together. First, we're going to do a public display of gratitude. We want you all that are attending to be aware of some of the key people and key faces that you should know and that you should be thanking for the enrollment and opportunity to participate in this course. Next, we'll spend a chunk of time giving you an overview of our course logistics so you know what to expect every session. And then we'll really get into the meat of it. We'll talk about implementation science and give you an introduction to this exciting field. And then we'll close very briefly with additional resources. And we'll spend the last 20 to 25 minutes in discussion groups. As big picture expectation setting, generally we'll be spending about 30 minutes on didactics, followed by 30 minutes of discussion. This week, because we have the course logistics to go through, we anticipate that this first portion will take about 35 minutes or so. So we'll have a little bit of a shorter discussion today. All right, so let's jump in with our gratitude. We want to thank the 2025 Course Planning Committee, all of the small group leaders, and all of the guest speakers. As you can see on this slide, it really takes a village to bring a course of this size and scope together. And we really appreciate everyone's time and participation. This is a free service that we offer to the Northwestern community, and we could not do that without the generosity of all of these faculty and staff. So just wanted to publicly thank everyone here. And then I really wanted to thank 3 women in particular. These are the true magic makers for this course. Dr. Sarah Helseth is our faculty director and lead of the Implementation Science Reading course. And then Emma Little and Jordan Viernes are our 2 lead coordinators. And to simply say coordination doesn't do justice to just the amount of magic that they do, bringing together the syllabus, working with all the instructors to make sure everything goes smoothly. And as you'll see when we go to the breakout rooms, they handle all of that logistics as well. And we're incredibly grateful for their time and expertise. I also want to bring your attention to the land acknowledgement here, just noting that the Northwestern campus does sit on traditional homelands and that we're very grateful to the Native tribes and communities from which we are able to use this land. All right, so the course objectives that we are going to try and address throughout our 9 and 10 week extravaganza here. And I say 9 and 10 intentionally because we have 9 weeks of didactics and 10 weeks of overall course. We're really guided by a review of the literature about implementation science research competencies. One of the awesome things about the field of implementation science is that there's been quite a lot of work kind of on a meta level of the science of science and understanding intentionally how to build this field and how to instruct people in the competencies for this field. So what you're looking at here are a list of competencies from a review by Padek and colleagues that really systematically looked at implementation research competencies across a beginner, intermediate, and advanced level. And we've very intentionally crafted this course to address beginner level competencies. And we have some specific ones that we've outlined today that we hope to attain. The first is we want to introduce you to some implementation research terminology. As part of that goal, we want to define clearly what implementation research is and also give you an inkling of what it is not. We also hope to make it clear to you how this field of research is different than other areas of research. We'll give you a very high-level overview of the potential impact of conducting this work, and we hope to also convince you that this type of research is truly cross-disciplinary and requires a range of expertise. And then we really are very intentional about taking space and exploring opportunities to define and operationalize health equity within implementation research as truly a fundamental platform for the work that we are doing. All right, and now I'm going to turn it over to Corey Bradley to walk us through some of our course logistics.
Absolutely. Thank you, Dr. Becker. And Sarah does such a great job of celebrating folks, and I just want to acknowledge your leadership and setting things up and just kind of leading us in a way that we can share this work that excites us so much. So thank you for your leadership in that space. And we have quite a feast for you all. It's really fun to be able to talk about these things and expand and explore with folks who have not been deeply introduced to the work, and it expands our learning as well. So here are a couple of opportunities we have through the course logistics. So there will be readings, 2 to 3 widely cited articles we'll ask you to read as required. And then there will be some supplemental articles that will reinforce those concepts. Those are, of course, recommended. And those with asterisks are readings that will help contextualize the case example that we use to move that work forward. Another aspect of our time together will be didactic presentations. And they'll be co-led by faculty. There are approximately 30 minutes, and these give you a sense of the fundamentals. We developed this kind of shared language so that we can talk about the ideas. They share basic and pragmatic methods that can be used across settings and populations, and then you'll have that information available to you within a week as far as the slides and the recordings. And then thirdly, maybe the most important in ways is the group discussion. This is your contribution, your reflection, and how you're sorting through these ideas. There will be groups of about 10 or so that have been developed based on shared interest, led by small group leaders. Sometimes I think maybe many of them have co-leaders. Each week, we'll also ask for you to help us lead. So we'll focus on the readings, and then we want to be clear that it's not a methods consult, but we'll be able to connect you and have enough rich conversation so that you can go into a consultation prepared. All right, we'll look at the next slides, please. Oh, yes, this is an important part of your co-leadership, right? That we'll ask you to be peer discussant, and in that role, you'll pose at least one question based on the readings. But everyone has the responsibility of raising points that inspire, confuse, interest you. And then we would love to hear you link examples of your own work or your own planning and experiences to the readings in the discussion. So pretty pleased, right? These are things that we have that we think will ensure a successful experience for all of the learners. Commit to at least 7 of the 9 sessions. Complete your readings before class, like Mom said, brush your teeth, right? So we know that's not always possible, but we hope you will be able to do that. Be sure to sign up as a peer discussion leader for at least 1 week. There may be times we might invite you to do that more than once. Keep your camera on and stay camera ready just for at least for your discussion. And so we can interact and facilitate strong interaction among your group. Please keep the syllabus with yourself and any NU colleagues unless you want to share, and in that case, please consult with us and first. And if these expectations, if you run into some challenges meeting these expectations, we may invite you to just consider waiting until next year.
All right, so thank you for that amazing overview of the course logistics. And so as Corey noted, we spend a chunk of time each week on didactics, and that's where we are today. So we are now ready to dive in. This is typically how we'll start in future weeks. We won't have the last 10 minutes that we just did together, but imagine now that we are starting with implementation science. What is it and why/how is it useful? One of your readings was the implementation science, the D&I bridge. and which really answers this question of what is implementation science in very user-friendly terms. And we define it broadly as the study of intentional, proactive methods that aim to equitably bridge the gap between what we know in terms of public health and medical knowledge and what we actually do in terms of public health and medical practice. And the argument that really drove that reading was that in prior literature, that's often referred to as this one big amorphous thing. We talk about bridging this gap between research and practice, but really we've argued that there are at least 4 gaps that need to be addressed, and that we need to address these gaps with intention and with a focus that centers equity to make sure that we're not exacerbating existing health disparities. And there were 4 gaps in particular that were really emphasized in that reading, and we're going to go through each of those briefly in turn. Before we do that, I do want to note that the reading did reference NIH definitions of dissemination and implementation research. You might notice the reading was about the D&I bridge, but this course is called the Implementation Science Reading Course, and that's because we've intentionally decided to focus on the I. So we think about dissemination research as defined by the NIH as really the study of targeted distribution of information and intervention materials to a specific public health or clinical practice audience. When we think about the reading, that's all about addressing demand. That's demand and awareness and knowledge of services and effective evidence-based practices. On the other hand, the I is the scientific study of the uptake of strategies to adopt and integrate evidence-based health interventions into clinical and community settings. That's really all about increasing the supply of effective services in community and clinical settings. And we've intentionally focused this course on implementation research because we felt like there was so much to cover that we really wanted to be intentional about giving you the steps to address the I. Last year, as a fun fact, we did an additional session on dissemination research. So if that's of interest to you, that session is recorded and on our website. It can be watched at your leisure. This year, we did not retain that topic. We instead expanded some of our other topics, as we'll preview at the end of today. All right, so why do we need D&I and why do we need the I in particular? Well, one way to answer this is with a picture, which is what we view as a really apt metaphor for the US healthcare system. And this is actually a picture that my husband and I took of the Grand Canyon from a helicopter over a decade ago on vacation. Basically, I love the Grand Canyon as a metaphor for the healthcare system because it is many gaps that intertwine and that form this one enormous canyon of grand proportions. And our healthcare system, I think, is very much like this as well. There's no singular gap. Again, this was emphasized in the article that you read, but it's really multiple gaps that intertwine that create this canyon, again, of grand proportions. Another metaphor or way to refer to this canyon as a synonym, is the word chasm. And in fact, that's the word used by the Institute of Medicine. They have a quality chasm series where they document the enormous gap between what we could be delivering if we used our best possible evidence versus what we actually do offer in terms of the healthcare that is available in our community. And the reason for this has been well documented in the implementation science field. And alarmingly, it's been noted that it takes about 17 years to turn only 14% of original research to the benefit of patients. And the reason for this is the 17-year odyssey that's now pictured on the right-hand part of your screen. There's such long, enormous lags between identification of research priorities, the process of peer review, the process of getting things published, the process of getting that into a research synthesis, to the ultimate process of getting things into guidelines. It's an extremely slow and leaky pipeline. We lose over 80% of our research, and the research that does benefit patients takes an unacceptably slow amount of time to do so. So part of implementation science is all about increasing the amount of research that is impactful and increasing the speed. Part of the reason, again, for this odyssey is just the status quo. We often go through stages of research in a very sequential and stepwise fashion. And what we want to challenge you all to do is to consider implementation from the outset. So even if you are doing pre-intervention work, or you are doing what you would consider a classically rigorous efficacy study, can you be thinking about the constraints of the system that you'll be delivering it in? Can you be thinking about the preferences of the patients and the people that will deliver it? And we're going to challenge you to consider implementation from the outset with the goal of accelerating that pipeline. Again, this course is not going to talk about gap 2 in much depth, but just to really wrap our heads around it, this is the gap between those who need health services and those that receive any care at all. And what we want to emphasize is that this number is extremely low across the board for health services. The percent of Americans that with a full diagnosis that receive any health service, as we see here, is only 20% for substance use disorders, only about 50% for mental health disorders, and only about 70% for physical disabilities. And that level of unmet need is the greatest among those of the lowest economic status and from racial and ethnic, historically marginalized and minoritized groups. So we don't only have a problem with insufficient supply in the community, we also have a problem that when treatment is available, people are unable to access it. Part of that is a knowledge issue and an awareness issue, but part of that is structural and systemic gaps that prevent people who need care from accessing it. And so all of those are issues that can be addressed by dissemination science. The third and fourth gap discussed in the reading were what we call methodological or scientific gaps and an expertise capacity gap. And we wanted to highlight both of those with one visual here, created actually by Hannah Chang, who's a graduate student here at Northwestern, and a team with the senior author Mark McGovern, where they took a close look at the historic funding in ending the addiction epidemic, the HEAL investment by the National Institute of Health between 2015 and 2019. That was 5 years of historic investment in funding by the NIH. And what they found was that less than 2% of research is what we, less than 2% of that funding is what we would classify as implementation research. The vast majority of federal funding is in what we would call discovery science. So discovering interventions and practices that work, but very little funding actually goes to thinking about how do we get that work to the people that can deliver it and to the people that can benefit from it. And so we really believe that we must create the infrastructure needed to advance the science. This is a young field of science, and we can't innovate if we don't have investment in this field. But also, we need all of you. We don't have enough expertise in this field yet. This is still a young area of science, only about 15 years old. And we need all of you and your colleagues to be interested in this area so that we can continue to grow. So that's exactly why we offer courses like this. As noted here, gaps 1, 3, and 4 are really the focus of this course. But as I mentioned, there is education about gap 2 on our website. And we're very excited to be addressing gap 4 by building your capacity to conduct this type of work. All right, so how do we do it? How do we bridge this gap, and how do we build the implementation science bridge? Well, let's answer this by talking first about the status quo. The status quo is that we typically think about an innovation or a thing, and we think about its effect on patients. That is very important, of course, but what that tends to ignore is a lot of context around that pathway. So it ignores, is that innovation reimbursable? Are there policies that support it? Does the setting where you would like this to be delivered have leadership buy-in? Does it have providers that are able to deliver this intervention, that have the appropriate training? All of that is context, which is a topic that we will focus on in greater detail in about 3 sessions. It also ignores the how. The how are you going to get the people that need to deliver this innovation to actually deliver it? Those are what we call implementation strategies. It also ignores a set of outcomes that might be important, such as, is this acceptable to the people you'd like to deliver it? Is it feasible for them? Can they do it with fidelity? And it ignores outcomes like, is it equitable? Is it timely? Is it efficient? All of that is the core of implementation research and where we will be spending a lot of our time in this course together. And to just really hit this with less jargon, I'm not going to belabor this because you can take this, you will have access to this slide, but this is from a paper by Jeff Curran and colleagues that really defines the concepts I just covered. So the innovation you'll hear us refer to as the thing. We think of implementation as doing the thing. And effectiveness research, which many of us are familiar with, is looking at whether the thing works, while implementation research is looking at how do we help each other to do the thing. We also are going to spend a lot of time talking about context, which are conditions that make it harder or easier to do the thing. We'll talk about strategies or actions we take to help others and each other to do the thing. And then we'll talk about implementation outcomes, which are how much, how well, and how equitably we can do the thing. So now I'm going to pause and turn it over to Corey. We just want to acknowledge we just threw a lot at you, and we're going to throw more at you in the next 10 minutes. We're going to talk especially about the need for an eye towards centering equity and keeping equity at the heart of all we do. And Corey, I'm going to pass it over to you.
Great. I hope you're feeling inspired because that's exactly what we intend to do, right? After you hear all of the challenges and by indirectly those opportunities, I hope you're feeling like, so what do we do? How do we take action? And so that's very much a part of implementation research. And for many people, you know, this requires a bit of a paradigm shift as we transition from kind of an efficacy, effectiveness, focus and research to implementation inquiry. And one of the really helpful ways that our team has talked about this is thinking about when you take the selfies or when you take photos in the portrait versus the landscape. So your intervention research is a bit more like your portrait mode on your phone camera, right? You're hyper focused on testing the intervention that's in front of you, and not quite, you know, including the delivery system that supports that intervention. It's a little more blurred. But pure or implementation research and in its inquiry is the opposite, more like the landscape mode, if your phone has that. So, right, that thing that's in the blurry part is now something that you are able to turn your attention to, and you're paying attention to the smudge that's behind the mirror in the selfie, right? All of those contextual pieces that give you more information about what you're seeing. So that's a privilege of inquiry and implementation research. Take the next slide. And we want to help kind of position you in your journey, both in your knowledge and in the practice of implementation research. And so this particular kind of schematic from Lane Fall and colleagues helps us go from the kind of practice of interest that you may be thinking about, asking the question, do we have evidence around efficacy? If no, maybe that's where we want to go first, to efficacy research with an eye toward implementation. And if yes, then we move a little further on that journey and consider the question of effectiveness. And if that has not been established and is important to the research question and stakeholders, then you'll move to effectiveness research. If not, or maybe partial, or thinking about organizations who kind of build their strategies as they go, right? You have an opportunity through a certain type of design, hybrid effectiveness implementation trials, to be able to entertain both the question of effectiveness and to keep an eye or engage in a deeper inquiry around how implementation might happen. I think Sarah has mentioned before that, you know, there in some, and I think it's behavioral health research, maybe we're besieged with effectiveness work and need to ask these questions around how we make use of this kind of evidence. And so hybrid effectiveness implementation trials help us with that. If yes, then we can also think about mixed methods to understand context better, how we want to engage the design of implementation strategies to get those interventions and that evidence into use, routine use, and its sustainability, and testing those strategies. So as we had mentioned previously, the notion of equity is interweaved. It's not its own discrete, but is foundational to implementation research. And the article from Bauman and colleagues talks about how you center healthcare equity, which I think there's opportunity in your groups to discuss this a little further. And some of the principles that they discuss, racism as a recognized as a fundamental driver of healthcare inequities. And I want to say, and I think we'll move to the click. Yeah, exactly. So it's suggesting even further that the inquiry is rooted in the fundamental causes of causal relationships of those of you who may be familiar with Lincoln Felon's work, the cause of causes, the fundamental cause of causes. So that is something I think when this article was written, we were in the height of Floyd, what's Floyd? Someone give me the name. Floyd.
George Floyd.
George Floyd, yes, did it backwards. But we want to acknowledge that there are other kinds of challenges, oppressions, marginal kinds of issues that generate marginalized populations, the challenges that they experience. And so those can be included in your contextual inquiry. Thinking about equitable healthcare requires multi-sector partnerships. And to that point, we would say that we want to add multi-level approaches, and we're thinking about it in getting away from kind of an individualized basis of analyzing the data or our information. We want to make sure that we pay attention to context, absolutely central to equity, and that acknowledging that context is not just the stuff in the background, right? But it's interactive, it influences, it modifies, it facilitates, and implementation research makes that the central stage piece, right? Something that we want to pay attention to see how things are working, the assemblage of all of those and how they contribute to the use of interventions to achieve health outcomes. And then finally, the equitable healthcare engages folks and is participatory. Ready for the next one. And a little further to think about how we're centering equity within implementation science. This article kind of talks about these key points that you want to focus on reach from the very beginning. You want to design and select interventions with populations in mind and implementation with those groups and populations. The questions are important around what works and the strategies that help you do the thing, but also while doing the thing, reduce the inequities in care that arise. We'll want to develop the science of adaptation and then absolutely use an equity lens for your implementation outcomes. So thinking about your implementation outcomes according perhaps to different populations and how they're achieving those through those strategies. This paper is a really great paper by Rachel Shelton and colleagues, and I love this visual particularly. So we're thinking about there's implementation practice and there's implementation research and implementation science, rather, I can say as well. And this article, this particular schematic says, let's think about applying, for example, an anti-racism lens to the science, right, to the discovery process related to implementation inquiry. And you can see all of these different aspects of implementation research and how that lens, and mind you, that lens also needs to be reflexive. That means that it also gives us an opportunity to see ourselves, bring ourselves and our positionalities into the research as well. And then this interdisciplinarity that comes through this lens by which we are able to move through the different phases and processes of making science. This article moves us a little deeper. I think I'm hitting you real strong if you haven't gotten the clue yet that equity is important in this work, right? And so this article by Shelton and Brownson sort of gives this overview of their perception of the grand challenges related to equity and implementation research. And it begins with, their listing begins with the multi-sectoral partnerships. And we'll talk a bit about partnerships, building partnerships and sustaining partnerships in the course, revisiting, reimagining the evidence base and how we are bringing consideration of underlying structural factors and social determinants, prioritize and elevate a focus on policy. So that's the development and enactment of policies that are aligned with the evidence that will advance health equity. And how do we dismantle the kinds of policies that disproportionately harm populations? Be agile, right? This inclusive in this space is the pace of research, being responsive regarding taking action and being adaptive or having an adaptive learning approach and using those in our strategies. Another perspective that is important is identifying and redefining equity metrics. What do those processes look like and what do they produce? What impacts are most meaningful? And we come to those kinds of understandings through participatory approaches and different frameworks that we use. And as Sarah began talking about dissemination, right, we don't focus on it here, but it is important to think about how our findings are disseminated and go across that gap that we described, right, into practice with diverse stakeholders and partners. How do we involve them early in thinking about dissemination efforts and making sure that the findings are reaching and impacting those who are systemically marginalized and in those communities and settings. And then lastly, they describe extending a focus on de-implementation, misimplementation, and sustainability.
Well, fantastic. I think you did what you set out to do, Corey, of inspiring. I know I always get so jazzed listening to you talk, so thank you very much. So one thing we really love to do in the course is plant the seeds of how this might apply to your own work through a case example. So we will have one case example that we will follow through every week in the course. This was assigned to you as a recommended reading. It was by Mello and colleagues, and it's about screening and brief intervention for risky drinking. And so since today is your orientation course, we basically just want to focus on some of the big picture concepts in this protocol and note for you that we will follow this throughout the course so you can see the different elements of implementation science and the implementation research at play. The first thing we want to know is that when you do implementation research, it's important to identify the gap. We spoke about the 4 different gaps in great detail. In this case, there was a supply side gap in the sense that level 1 pediatric trauma centers across the country are certified by the American College of Surgeons. And it is a mandate to be level 1 certified that you should screen all youth for alcohol use and provide appropriate brief intervention to those that screen positive. That is because of the public health significance of this issue, that many youth admitted to pediatric trauma centers are there because of alcohol-related incidents. And if they are not there due to alcohol, there's also the reality that many will be discharged on an opioid if they have a serious injury. And it is well documented that any history of alcohol use increases a teen's likelihood of becoming addicted to and or having an opioid use disorder in the future. So for a number of reasons, screening for alcohol use can really improve long-term outcomes. So this is what's often been called a pivotal or a teachable moment for youth and families. It's also been well documented that when providers are left to their own devices to screen based on clinical judgment, that sometimes that is not applied equitably and that there's racial bias in who is screened and who is left out of screening. So for a variety of reasons, we really wanted to promote universal screening and improve the supply of universal screening across pediatric trauma centers. So the thing, which we'll talk about more in 2 sessions, was a screening and brief intervention and referral to treatment protocol recommended by a number of national organizations. And before things were started, a first step was really understanding the landscape. So the team conducted a review of the literature and also surveyed all 10 pediatric trauma centers that were interested in participating in this initiative to really understand their landscape and their climate. And in future weeks, we'll talk about this in great depth. What I want to note is we actually do have a change to your reading course syllabus that will be communicated to you after today. But basically next time for session 2, we will be talking about theories, models, and frameworks. So we'll talk about the specific frameworks that guided this case, and you'll learn about a number of different types of frameworks. Then we will be switching the order, and what is now listed as week 2 will become week 3. And we'll talk about how you select your thing, Then we'll talk about contextual determinants, then implementation strategies, and then outcomes, all of which will be previewed next time in theories, models, and frameworks. And I want to thank our course leaders because we are always continuously trying to improve, and we're in close contact, and the instructors made that decision to try and have a more cohesive experience for you over the next few weeks. And I'm very grateful to them for that pivot. All right, so one thing I want to know is if in today you've been like, oh my goodness, I have all these questions that you think will be beyond the scope of what we can answer in our small groups, we just want to note that at any time you can request an implementation science consult from our team. Corey joked that our small group discussions are not meant to be consults, but we do have a place for that. So if you need a consult, just go to this form here. You can Google CDIS Implementation Science Consult. We can also share the link with you, and we'll make sure this slide has the link on it. And you can click Request a Dissemination and Implementation Science Consult, and you'll get a free consult with our team to help you with the methods of a specific issue. All right, so final thoughts. I do want to reiterate that in future weeks, the didactics will be shorter. Today, we had about 10 minutes of overview of course logistics. So in the future, plan on about 30 minutes of didactics, 30 minutes of a small group. Today, it'll be more like 20 to 25. But since it's the first time, we'd really love for you to get to know your group. So please take a little bit of time to introduce yourself. We encourage you to share your name, your specific role at Northwestern, or if you're a Northwestern affiliate, how you are affiliated, some of your interests, and then take a shot at trying to find yourself on the implementation science subway and share with the group where you think your work historically has been situated. We will also ask that before your group ends today that you sign up for a peer discussant role. The small group leaders will have the link to a Google Sheet where you can do so. And then take your time and discuss the readings. Your small group leaders do have some example questions, but please also take this time to let us know questions that you have about implementation research that you really hope to get answered by the end of the course, so that your small group leader can make sure to be intentional about that over our time together. We will also be sending you a link to this recording on SharePoint, and it says see you the same time next week, but that is not true. It is the same time in 2 weeks. So 2 weeks from today, we will see you again virtually. All right, and now here is where, if you were here when I thanked the Magic Makers, your Magic Makers, Emma and Jordan, will be assigning you to small breakouts. That sometimes takes a couple moments, so just bear with us.